Hello. This evening we will be presenting on the PAR program, the Partner Assault Response Program. Our presenters tonight are myself, Kara, Saba, Rasha, Jenny, Gabriella, and Camila, sorry. All right. For our agenda, we're going to cover what is involved with IPV or intimate partner violence. We'll dive into the background, what's the repeated offenses, issues with reporting, and the importance of the topic in relation to social work. Then we'll get into our research methods, and finally end with our literature review and the question for our research. And with that, I hand it off to Gabriella.
Thanks, Kara. Okay, we are going to start talking about intimate partner violence, IPV. IPV is a serious public health issue that affects millions of people around the world. Those who experience IPV often do not report it to the police for different reasons, such as fear of stigma, shame, or lack of trust in the criminal justice system. In Canada, women represent the majority of victims of intimate partner homicides, accounting for 80% of people killed by a partner between 2014 and 2020. In 2020, 160 women were killed in Canada. In 2019, of the 108,810 people aged 15 and over who experienced IPV, 79% were women, 3.5 times higher among women than among men. 67% of LGBT+ women had experienced at least one type of IPV since the age of 15, compared to 44 among heterosexual women. 55 of women with disabilities reported experiencing some form of IPV in their lifetime, compared to 37%. 40% of women who experience domestic violence return to their abusive partners. As IPV offenders rarely seek treatment on their own, current interventions are usually court-ordered. The Duluth model and CBT are two common treatment options for IPV, which are often referred to as Batterers Interventions Programs, BIPs. So what is PAR? Next, Kara, please. The Partner Assault Response is a domestic violence court initiative that delivers community-based group interventions programming to domestic violence offenders. It is an early intervention used after first domestic violence offense, not involving a weapon or resulting in serious injury. It is funded by the Ministry of Attorney General's Ontario Victim Services and provided by community agencies. It involves 12 modules and a final assessment and report. And the main goals are changing men's attitudes toward violence, supporting and ensuring women's safety, and informing the broader system of justice and advocacy professionals about men's progress. Next, please. And some topics included in the programs are, for example, how to build a healthy relationship, dealing with conflict, responsibility and accountability, and they are based on some principles such as abusive behavior is a choice, or domestic violence is a crime, and also domestic violence offenders and victims or partners have the right to be treated with respect. It is a program that does have a fee, and services providers determine the fees based on the person's specific needs and income, and fees can be negotiated. And now I'm going to pass it to Saba.
All right, so I'm just going to give a brief background as to what intimate partner violence is, which I'll be referring to as IPV. So next slide, please. So what is intimate partner violence? Usually it's categorized into 3 categories. And the first is psychological violence, which encompasses forms of abuse that target a person's emotional, mental, or financial well-being, or impede on their personal freedoms or sense of safety. This category includes jealousy, name-calling, put-downs, and stalking as well. The second point is physical violence, which includes forms of abuse that not only involve physical assault, but the threat of physical assault. And this could include things being thrown at the victim, being beaten, being slapped, being choked. And then there's the final one, that's sexual violence. And this includes sexual assault or threats of sexual assault. And it's measured by being made to perform acts of sex that the victim did not want to perform, or being forced to attempt to force the victim into having sex. Next slide, please. So this graph just shows how hand in hand women and men go through various forms of physical IPV. And you can see men and women are almost at par when it comes to this. And most of the time women are leading in being the victims in IPV. Next, please. So repeated offenses, this is very crucial to our topic. And the issue with IPV is how often the offense is repeated. Stats Canada actually did a little finding in their research. And what they came up with was that 30% of women and 27% of men stated that at least one type of IPV, and that could be physical, sexual, or psychological, had occurred repeatedly. And repeatedly meaning either on a monthly basis or more often. And likewise, over half the women, 54%, and men, 51%, who experienced IPV said that at least one specific abusive behavior occurred a few times over the past 12 months. And that is more than one time, but less than a monthly basis. And like I said, this is really important because this is what needs to be considered for future programming. And the goal is always to stop repeated offenses from occurring. Next slide, please. So I try to gather from all our literature review what the possible reasons to IPV can be. And I kind of came up with 4 factors. The first being the lower household income associated with lifetime experiences of IPV. And in households with incomes of less than 20,000, lifetime experiences for IPV were common for women and both men. Studies also found that experiencing IPV in one's lifetime may be a factor that leads to relatively lower income later on, which is usually a barrier to leave IPV situations for the person with the lower income. And the second issue is emotional abuse as a child. So intergenerational violence can stem from emotional abuse during childhood, which has been shown to be associated with an increased risk of intimate partner victimization in adulthood. The other side to this is how prone to being the victim and in IPV is amongst people who have experienced abuse as a child. The third factor is risk of intimate partner violence varies across populations. So people from population groups reported higher than average rates of IPV, and that included sexual minority people in the LGBT community that are more likely to experience all forms of intimate partner violence than heterosexual people. And you can see some stats there as well, just to have a comparison. And more than 55% of women with disabilities, this was an interesting one, experience some form of IPV in their lifetime. And finally, a higher portion of Indigenous people experience spousal violence. So while 3.4% of non-Indigenous people experienced spousal violence in the past 5 years, the prevalence was more than twice as high for Indigenous people, which was 7.5% reported. Indigenous groups face high rates of IPV due to historical, intergenerational, colonial reasons, but that goes further than the scope of this presentation. And on this graph, you can see some impacts of IPV, but the most prevalent was PTSD. Next slide, please. So issues in reporting. Studies and literature have been pointing to the gender issues in reporting. There's a major gender gap between reporting IPV for women and IPV for men. One example is not reporting due to masculinity roles. Men are less likely to seek informal and formal help in the first place. And if they do seek out such help, there's generally less services for victims who are men than there are for women. And women actually go unreported due to a foundational belief system. The 2 most common reasons they gave was not reporting spousal violence to the police, were a belief that the abuse was a private or personal matter and a perception that it is not important enough to report. And this usually comes from a cultural standpoint. And in all large majority, 80% of spousal violence victims said that the violence they experienced was not reported. And some of the issues in programs that they stated was, or barriers, you can say, the majority of IP victims had not used or consulted a formal service in the past 12 months. And the most common reasons they gave was that either they believed they didn't need the help, the incident was too minor, there were barriers to accessing the program, and that could have been the victim's language wasn't available, or the services were too far away, or there was a waiting list, or for financial reasons. So I'm going to pass it on to Russia now.
Thank you, Saba. So IPV has a big impact on its victims and the people exposed to it. So it's important for social workers to understand the effects this can have on people so we can better support them. So as Saba mentioned, intimate partner violence has long-term effects and can cause intergenerational trauma. Therefore, it is important for social workers to use a trauma-informed lens with our clients. Based on our research, we found that psychological, physical, and sexual violence can lead to different problems on the long run. So understanding the root cause of our clients' problems will be helpful in determining the type of therapy that can be most effective. But not only do we have a role in helping the victims of intimate partner violence, as social workers, we also have to uphold our ethical principle and uphold our social work core values, which in this case is respecting the dignity and worth of the person. What this means is that we have a role in helping the person causing the violence. As social workers, we must be mindful of the perpetrator's circumstances in these scenarios, as they may have been victims themselves and may have unresolved trauma that needs to be addressed. Social workers in this case can also help such individuals through counseling, programming, and addressing the root cause of the behavior. IPV has major psychosocial implications for both the survivors and our society. Social workers have an important role to play and to examine closely the at-risk factors for being a survivor of IPV, strategies to prevent IPV and programs, services, legislation, and policies for addressing the physical and psychological aftermath of IPV. Social workers should also use a trauma-informed practice to help victims of this type of violence. If we can change the slide now. So as we can see on the slide, at least 15.5 million children in the witness domestic violence are in it annually. Repeated exposure to violence and the related trauma can affect children's health, ability to succeed in school, likelihood of becoming a victim or perpetrator of violence. So youth who have been exposed to violence are at a higher risk of engaging in criminal behavior as adolescents. Witnessing or experiencing violence has been linked to lower grade point averages, more negative remarks in cumulative records, and more reported absences from school. There was a study in 1995 called the Adverse Childhood Experiences in Adults, and it found a significant relationship between childhood experiences of abuse and violence and a host of negative adult physical and mental health outcomes, including heart disease, stroke, depression, suicide attempts, and sexually transmitted diseases and substance abuse. Trauma-informed social workers who provide services to at-risk children understand that risk and protective factors for the child, family, and community can affect the ways in which children and teenagers process and understand the exposure to violence. In this context, the role of social workers to promote resiliency, which is the maintenance of healthy and successful functioning in the face of significant adversity or threat. I will pass this along to Jenny now.
Thank you. So now I will review our keywords, search strategy, and search databases. First off, I started to develop our search strategy by identifying the keywords and concepts within our research question. The aim was to identify the words likely to have been used in published literature on this topic. As shown on this slide, the keywords and concepts identified were partner, assault, response, intimate partner violence, mandated, and reducing. Next slide, please. Illustrated here are the search strategies that I utilized. From the identified keywords and concepts derived from the research question, I then looked for the singular and plural forms of words, variant spellings, acronyms, and relevant index terms such as subject headings. For example, synonyms of partner were batterer and perpetrator that were listed on the previous slide. I then referred to selected library resources to search, which included journal databases. And then to further that, I looked at search resources, which included the Boolean operators, proximity searching, as well as truncation searching, which included asterisks, hashtags, as well as question marks. And then followed by the review and refining of our results, which meant rethinking keywords and creating alerts for ourselves and really putting everything into a simple document for us to look back for citation using. And now I'll move that over to Karen Cam. Oh, sorry.
Okay, so after analyzing the articles we collected in our references, I will quickly summarize the main and recurring strengths and limitations found, beginning with the strengths. One of the main strengths that we found is that many actually took on an intensive, thorough measurement that focused on the correlations of all factors of male participant dropouts. So this developed an accurate preliminary description of the men who failed to complete this program. And as mentioned, most of the clientele are males in this program. Again, many of the studies also took an intersectional approach. This was good because it showed that the program's integrity was reliant on this approach. There was also reoccurring focuses in all the studies on violent-related factors, such as court referral, criminal history, child abuse, battering history, and these forms of measurements have an excellent face validity. In terms of location, for the studies, most were done in North America, as close as Toronto, which means they all include a diverse sample of multicultural participants. So it takes into account most cultural related effects. Most studies focused on the participant observations, which gains an insider's view. As well, many of these studies focused on refining the interview questions and were pilot tested beforehand. And this is a crucial part of the interview process because this is where it produces the quality data and helps identify weaknesses and overall improves the research accuracy. And finally, studies were conducted in the program's everyday settings, and this interview questions were also designed to be relatively easy for all participants to answer. So that left a little space for misinterpretation. Next, I will move on to the limitations that was found. Firstly, we did not find much recent studies that were held in the past 5 years. And more than 90% of our studies found were conducted only on males. So there was a lack of research on female perpetrators and effects of being in the program. A lot of our studies as well were meta-analyses, and those do tend to decontextualize the evaluations and still require interpretations. Also, most of our studies were found to focus too much on the perpetrators and not enough focus on the victims and their outcomes after their partners left this program. As well, many articles had different forms of measurements within them, which led to uncertainty and inaccuracy of the results. For instance, there was differences in calculating dropout rates across studies. Some researchers calculated rates from men's initial contact within the program until completion, whereas others calculated rates from intake to the end of the treatment. There was also retrospective biases found in the demographic information. For instance, if participants in the studies are recently divorced, they would describe themselves as unmarried, or they identified within 2 races and they only had to choose one. Even the frequent changes in the residency and employment led to inaccuracy. It was also found that in the studies, the staff delivery and format varied. So this can limit the integrity and usefulness of the results. And finally, many of the interview samples were found to be too small, such as 19 participants or less. Therefore, the discussions regarding experience provided only a partial view. I'll move over to the next slide now.
Thank you, Cam. So looking at our literature review at this point, there were several themes and gaps in literature which stood out to us. Some of these gaps in literature are things that Cam has just discussed as limitations, such as the form of IPV not being specified in the research, and as well as not only there being lack of recent information, but also lack of Canadian research or research that was specific to the PARS program. One of the best sources of pieces of literature we came across was actually dated from, I believe, 2006. And that was a review of the PAR program within Canada and had a nice large scope to it, but still there was nothing else following that really. As well, another big gap is the limited research on various ethnic minorities. This was discussed in numerous studies and noted specifically in regards to the states as well, differences in findings of research when Latino populations were involved, whereas the Canadian research is lacking more information on Indigenous populations, etc. So the themes that we found that came up regularly: research focused on male to female violence, female to male violence, was viewed as less harmful and therefore not as big as of an issue. When these researchers found that men were still physically abusive following intervention programs, it was suggested that these individuals might still be abusive no matter what intervention was used, and this may be a result of things such as mental health issues or personality disorders that the research hadn't tried to capture or been able to. Overall, most of the research pointed to the idea that some form of intervention is preferred to none. Even in the cases that we don't see any change in the perpetrators' views, behaviors, or anything, there's the feeling that something is better than nothing, which I think we can all understand and expect as respect as social workers, that we'd rather be trying to make noise and be like, this is an issue, rather than nothing. Finally, the intervention programs are seen as only a small piece of what is needed to address intimate partner violence within the various systems of society, not to mention the unique situations that are present in each different community. All right, and I'll pass it back to Samba.
All right, so basically all our research and literature review led us to this one question, and that is, how effective is the mandated PAR program in reducing intimate partner violence incidences through changing the attitude of the perpetrator? So basically, what effect does the PAR program have in changing the attitudes of the perpetrator so they don't reoffend? Next slide, please. Sorry, next slide. So yes, we also had a hypothesis based on our question and our literary review, and that a certain level of readiness for interventions is necessary for there to be an impact of the PAR intervention. Previous question. Previous slide.
And we will come back to the real world now and talk about your questions. Thank you.